The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Contraception. So, pwede pumunta sila sa'yo asking regarding options for family planning. So, sa family planning, meron ang WHO na 1, 2, 3 tier. Okay? So, ano yung 1, 2, 3 tier na yon? Dito sa tier system na to, yung 1, yun yung pinaka-effective. Hanggang yung 3, yun yung least effective. Okay? So, parang kumbaga, kinlassify niya yung mga family planning methods into the most effective to the ones that are least effective. So, isa-isahin natin yung each tier, starting with tier 1. So, first in our contraception under tier 1 is your implant or your Implanon. Yun yung pinaka-common na brand na naririnig natin. So, ano pa ba yung ibang kasama sa tier 1? So, pag sinabi mong tier 1, it is highly effective such that fewer than 1 pregnancy per 100 women in 1 year ang nabubuntis. Okay? So, yung iba pang methods under tier 1 are your IUD, implants, male and female sterilization. Okay? So, i-discuss naman natin to isa-isa. So, yung Implanon mo or implant, ang kanyang primary hormone is etonogestrel. Etonogestrel is a form of progestin, no? So, hanggang kailan mo siya pwedeng gamitin? Hanggang 3 years. So, si Implanon, kaya siya implant, kasi nilalagay mo siya sa subcutaneous layer mo sa forearm. Okay? So, para siyang palito. So, kapag papagalaw mo siya sa patient mo, makikita mo, mapapalpate mo yan, yung Implanon sa kanilang forearm. Okay? So, anong maganda about Implanon? So, Implanon being a progestin, has several side effects. So, ano yung mga side effects na yun? Also, when you appraise the patient, isasama mo siya, pwede ka magkaroon ng headache, acne, pwede ka magkaroon ng intermenstrual bleeding or spotting, and yung pinaka-feared side effect ng mga progestin is decrease of bone mineral density. However, sa etonogestrel implant, hindi yun nakikita, no? Kasi well-distributed yung release ng etonogestrel for the next 3 years. Okay? So, ang mechanism of action niya is ovulation inhibition and thickening of the cervical mucus. So, that's your Implanon for you. Ayan. So, next tier 1 method is intrauterine device. So, we have 2 kinds of IUD. One is copper. The other is levonorgestrel containing na IUD. So, si copper IUD is good for 10 years. So, anong mechanism of action niya? It induces local inflammatory reaction sa endometrium such that it will become a hostile environment for the sperm so that fertilization will not occur. Okay? So, yun ang mechanism of action ng copper IUD. Now, levonorgestrel containing IUD is another form of intrauterine device. Ang brand name for this is si Mirena. Okay? Siya lang yung alam namin na brand for levonorgestrel containing intrauterine system. So, this is good for 5 years. So, si copper IUD, good for 10 years. Si Mirena, 5 years lang. So, ano yung primary effect ng levonorgestrel sa loob ng matres? So, it thickens the cervical mucus. It impedes sperm penetration and access to the upper genital tract. Tract to dapat, hindi track. Okay? It also decreases tubal motility and produces a thin, inactive endometrium. Okay? So, it also causes low levels of circulating steroids, sometimes inhibiting ovulation. So, ito yung mechanism of action ng iyong Mirena. Okay, so kailan ka nag-i-insert ng Mirena? So, on any day, as long as sure ka na hindi pregnant yung patient. Second, if immediately post-abortion yung patient, pwede ka mag-insert agad ng IUD. Third is immediately postpartum following vaginal or cesarean delivery. Ang caveat lang dito guys, warning lang, mataas yung risk na ma-expel to ng women, 'di ba? Ng women. Kasi 'di ba, naka-open pa yung cervix nila postpartum. So, mataas yung expulsion rate nila compared to the other types that when you will insert intrauterine device. And fourth is for emergency contraception for up to 4 days following unprotected intercourse. So this is a form of emergency contraception. Kung halimbawa ayaw nyo maging pregnant and you had an unprotected intercourse for the past 5 days. Okay, so what are your contraindications for IUD insertion? Una sa lahat, pregnancy or even suspicion of pregnancy, acute pelvic inflammatory disease, postpartum endometritis, or infected abortion. So kapag meron kang septic abortion na patient, induced abortion, hindi pwedeng IUD ang form of contraceptive mo sa kanya postpartum. Known or suspected uterine or cervical malignancy for obvious reasons, genital bleeding of unknown origin, and a previously inserted IUD that has not been removed. So obviously that's a contraindication to insertion of another intrauterine device. So these are your other tier 1 methods. For the males, it's vasectomy. So just take note na hindi immediately sterile yung male factor mo ay yung male partner mo after vasectomy, no? So advise them na ilan pang ejaculation saka talaga completely magiging sterile, rendered sterile yung male. And so for the females naman, it's bilateral tubal ligation versus bilateral salpingectomy. So kailan kami nagsa-salpingectomy? So nagsa-salpingectomy kami guys kapag nag-offer kami sa patients ng opportunistic prophylaxis against ovarian cancer. So why? Because salpingectomy removes possible STIC. Your STIC stands for serous tubal intraepithelial carcinoma, which they say is the precursor for ovarian cancer. Okay? So pag tinanggal namin yung bilateral fallopian tubes, malalessen yung chance na magkaroon si patient ng ovarian cancer in the future. Okay? So kaya bilateral salpingectomy na yung karamihan ngayon ng mga OBGYN. But otherwise, we still offer bilateral tubal ligation. Yes. Yeah. So those are your tier 1 methods. So these are the highly effective methods for family planning. So let's move on to tier 2. So ano yung mga under tier 2? Injectables, pills, patch, and ring. So dito sa apat na to, itong injectables and pills, ito lang yung mga mostly ma-encounter nyo in practice, no? So injectable, ang pinaka-common dito sa Philippines is your dipomedroxyprogesterone acetate. 150 milligrams intramuscularly every 3 months. Okay? So, ito yung mga ayaw natin na side effects ni DMTA, irregular bleeding pattern. So, bakit? Because it causes thinning of the endometrium. So when your endometrium is thinned out, the atrophy causes parang nagkikis-kis yung endometrium with each other, causing atrophic vaginitis. So yun yung nagko-cause ng irregular bleeding pattern in patients given the MPA. Weight changes, so ayaw na ayaw to ng patients natin. Headaches, mood changes. So these are just some of the side effects of your DMPA. So ang isa sa mga ayaw natin na side effect is bone loss, okay? So this is reversible if taken less than 2 years. So as much as possible, we don't extend our use of DMPA beyond 2 years. And when we do give DMPA to our patients, we have to give them calcium supplementation along with the DMPA, okay? To help with this side effect, the decreased bone mineralization or bone mineral density. Okay, so kailan ka pwedeng magbigay ng DMPA? Anytime during the menstrual cycle, as long as the patient is not pregnant. So it goes without saying, guys, when you give contraception to your patients, dapat na-ensure mo na hindi siya buntis at all. So, for example, may mga strict na mga OBGYN, before they give the MPA, the patient has to take a pregnancy test first to make sure na hindi siya buntis. So if this is given later than 7 days into the cycle, backup contraception should be used for 7 days. So an example of a backup contraception, pwede silang mag-barrier method in the form of male condom for the next 7 days if the DMTA is given later than day 7 of your cycle. Okay, so next form of contraceptives under tier 2 are your pills. So dalawa lang yan usually guys, progestin-only pills or your POP and your combined oral contraceptive pills. When you see progestin-only, so obviously progestin lang yung component niya. Isa lang yung component hormone. When you see naman COC, combined meaning may combination ka ng estrogen and progestin. Okay? So what it does is it inhibits ovulation. So yung mga progestin-only pills natin, 28 days, 28 tab packs usually yan. So you take that continuously and dapat same time of the day, every day. So why? Because yung progestin mo, it has an ovulation inhibition dose. And nare-reach niya yung steady ovulation inhibition dose within 48 hours pa. Okay? So ang ginagawa ng progestin is that it suppresses your luteinizing hormone. Remember our menstrual cycle, di ba? Yung after ng LH surge mo, when your corpus luteum takes over, tas may progesterone siya na napoproduce, yun yung parang minimimic ni progestin. Okay? So, the progestin inhibits your LH. So, di ba, as I mentioned, important to guys, within 48 hours pa magiging steady yung amount, and magiging steady itong ovulation inhibition dose mo ng progestin-only pill. So, important siya when I discuss later on yung regarding sa missed pill. So, take note of that, 48 hours yun. So, yun siya. So, basically, what it does is it inhibits ovulation by suppressing your luteinizing hormone. Now, your combined oral contraceptive pills, usually the estrogen is in the form of ethinyl estradiol. So, ang kadalasan na composition ng pill pack mo is 21 days. 21 days lang yan na hormonally active plus 7 days na pill-free. Ibig sabihin, when you instruct your patient, 21 days mo siyang tuloy-tuloy iinumin, may 7 days na hindi ka iinom ng pills. Okay? Tapos, you will expect na within those 7 days, doon ka rireglahin. Alright? So, nag-ovulate ka ba? Nire-regla po pala ako eh. So, mag-ovulate ako. Hindi ka nag-ovulate, guys. Hindi kayo nag-ovulate kapag naka-pills kayo. Alright? So, may iba po bang preparation, doktora? Kasi yung iba 28 days. Yes, may ibang preparation. Doon sa mga 28 days na yung laman ng pack, it means na 21 doon yung hormonally active. Yung 7 doon are usually just ferrosulfate. Okay? So, ito yung kadalasan na available sa market natin. Meron pa tayo ng mga iba-iba, mga multiphasic na tinatawag, pero I haven't seen in practice anyone using yung mga multiphasic. Ibig sabihin ng multiphasic, iba-iba yung dose mo. Depende kung anong part ka na ng pill pack mo umiinom, no? Pero most of the time, isang dose lang yan for all the pills in the pack. So, they all share the same dose. So, next. Yan. So, how do you take it? So, ideally, this is how you should be taking it. You take one pill regularly, preferably at the same time of the day, every day, especially if you're taking your progestin-only pills. Okay? Kasi it takes time for the progestin to reach the ovulation inhibition dose, okay, to suppress your LH. And then, you usually start within the first 5 days of the menstrual cycle. So, parang kasing sasabayan yung what's supposedly your menstrual cycle for that month. But it may be started anytime, provided that for 7 days, if you start beyond day 7 of your menses, kailangan mo nang mag-backup method. Okay? Mag-backup contraception. So, Doctora, what will happen if I miss my pills? Okay. So, kapag 1 day ka pa lang nakamiss ng pills, okay lang. Take the pill ASAP. Okay? No backup required. 2 pills, pwede ka pa rin namang pwede ka pa rin mag-take ng 1 pill ASAP, okay? Tapos, mag-take ka rin later on, pwede rin, habulin mo yan, sige, go. Basta ito, walang backup contraception required, yung 1 or 2 pills na miss. Pero, kapag naka 3 pills ka na, ito na yung kailangan mo ng backup. remember kung kailan natin na-reach yung ovulation inhibition dose, it's 48 hours, diba? So, kapag nakalampas ka na doon, most likely hindi pa inhibited yung luteinizing hormone mo at this point. So, pwede kang masingitan dyan ng LH surge mo. So, what you do is you use backup for the next 7 days, okay? And if there is intercourse within the past 5 days, you have to employ or you have to use an emergency contraception. Okay, malinaw? So, again, pag 3 missed pills, kailangan mo ng backup contraception. Okay? Backup contraception, and kapag nakipagtali ka within the past 5 days, you have to take emergency contraception. Ngayon, that is if you miss the pills for the first 2 weeks. Pero pag na-miss mo siya for the 3rd week, you just start a new pack right away. Okay? Para ka na rin, kasi nasa ano ka na yan kumbaga, past day 14 ka na yan, going to day 21. So, doon ka na lang, mag-new pack ka na lang, para hindi ka malito. Okay? Pag basta doon ka na sa last week, sa 3rd week ka na, mag-new pack na lang instead of using the current pack that you're using. So, malinaw, no? Basta, ang tandaan nyo, pag 3 pills na yung na-miss mo in a row, you have to do backup contraception for the next 7 days and emergency contraception. And kapag nasa 3rd week ka na, start a new pack. Discard na what you're currently using. Okay? So, what are your absolute contraindications? This is for your combined oral contraceptive pills. So, ang estrogen kasi, it will render you coagulable. So, basically, kung iisa-isahin pa natin to, hindi ko na iisa-isahin, no? Medyo marami. This is found in blueprints, this table. These are the contraindications to your COCs, okay, to your combined oral contraceptive pills, because baseline may mga hypercoagulable na itong mga diseases na to. So kung magbibigay ka pa ng estrogen, you will render the patient na mas hypercoagulable. So you will incur morbidity in those cases. So we don't give COCs in those cases. So ano yung mga examples? Thromboembolism, pulmonary embolism. We don't give those to our patients with we don't give combined oral contraceptive pills to these patients. So, ano pa ba? Ito, endometrial cancer or breast cancer. Usually, these are hormonally responsive tumors, especially your endometrial cancer. So, magbibigay ka pa ba ng more estrogen sa may endometrial cancer na? Okay, so mas matitrigger mo lalo yung endometrial malignancy in this patient. So, no more na, no? Hindi ka na pwedeng magbigay ng COCs in cases with breast or endometrial cancer. So, hindi na natin isa-isahin lahat, but basically, ang pinaka-concern mo is the hypercoagulable component or hypercoagulable factor ng estrogen in your combined oral contraceptive pills. Okay. So, another tier 2 methods na admittedly I haven't used for my patients, I don't know anyone who's using this in the Philippines, are your patch and your ring. Okay, so ito si patch, ito si ring. Parehas lang sila na may estrogen and progesterone component. Therefore, ang mechanism of action nila is inhibition of ovulation. Guys, remember when I was presenting to you the menstrual cycle, di ba when you have your gonadal hormones, what happens is your gonadotropins are inhibited. May negative feedback sila. Remember, yun yung sa luteal phase, no? Na nung tumaas yung estrogen and progesterone, mababa yung gonadotropins mo or your FSH and LH. So in effect, it inhibits your ovulation. So ganun essentially for all the hormone-containing contraception. So patch and ring, they're the same, no? Because of the estrogen and progesterone na inhibit yung ovulation. So how do you use this? Parehas sila na 3 weeks on, 3 weeks nakalagay yung patch, or 3 weeks nakalagay yung ring, and then 1 week off. Yun yung parang rest period, yun yung parang pill-free period for this form of contraception. Now, hindi na natin masyadong i-discuss yan because we move on to the other tier naman, to the tier 3 methods. Okay, so ito yung least effective. So these are your barrier methods. So kasama na dito yung male condom. And then these are your other forms of barrier method, your diaphragm, your cervical cap, and your female condom. Now, I don't want to discuss too much about the barrier methods because these are really not readily available in our country, no? So dito na lang tayo sa next tier 3 method, which is your lactation amenorrhea, okay? So si LAM, lactation amenorrhea, essentially what it does is that it backs on your prolactin, which inhibits your GnRH. So again, everything else down the cascade of your HPO axis is inhibited or is decreased because of the inhibition high up in the hypothalamus, no? Sa GnRH level pa lang. So, sino yung pwedeng mag-lactation amenorrhea method? So, those na hindi pa bumabalik ang menses, no? So, ibig sabihin, hindi pa sila nag-ovulate, hindi pa bumabalik yung fertility nila. So, if you're still amenorrheic within 6 months and you're exclusively breastfeeding, you may perform lactation amenorrhea method as a form of contraception. Okay, so these are the other methods, calendar rhythm method. So anong ibig sabihin nito? So remember, tinuruan ko kayo kung paano mag-compute ng cycle. So you will look for the longest cycle and the shortest cycle. For the shortest cycle, minus mo doon 18. For the longest cycle, minus mo doon 11. So yung makukuha mo na difference is yun yung interval na fertile ka. So doon ka hindi magsisex. Okay? So for example, 30 minus 18. Ayoko na mag-compute. Okay, hindi, sige, sabihin natin 25 minus 18. So 7. Okay? So 7. Yun yung shortest cycle mo. Tapos 30 minus 18. 30 yung longest cycle mo. 30 minus 11, so 9. So, di ka pwedeng mag-intercourse between day 7 to 9. Okay, sobrang short naman na period nun. So, anyway, that is, kunwari lang, parang ganon, example lang. So, standard days method, so instead na magpo-compute ka ng fertile period mo, you just abstain for the next few days 8 to 19, okay? So again, ang day 1 mo is the first day of menses. So you abstain, you don't perform sexual intercourse dito sa days na to. So yun yung standard days method. Okay, so other forms of contraception, ito is mga fertility awareness na methods to eh. So basal body temperature. So refrain from vaginal intercourse from day 1 of menses until 3 days after the temperature rise of 0.2 to 0.5. Okay? So ito yung basal body temperature method. Next is Billings ovulation method or cervical mucus method. Ito naman, you observe the quality of the vaginal discharge, no? In the presence of clear, wet, and slippery mucus, you refrain vaginal intercourse until the 4th day after the peak of wetness. Okay? So, yun yung Billings ovulation method. Symptothermal, i-combine niya yung DBT saka itong Billings, no? So, kailan mag-refrain from sexual intercourse? When the woman senses cervical secretions and the third full day after the rise of the basal body temperature. Okay, so bakit ganun, no? Kasi di ba around the time na mag-ovulate, umiinit yung temperature mo. So, yun kasi yung basis niya. Yun ang basis ng symptothermal sa kanong DBT. Alright, so sa 2-day method naman, once she notices any secretions, any type, color, or consistency, the couple should refrain from vaginal intercourse on that day and the day after. And finally, saliva ovulation monitoring. So ito very tedious to guys. The couple should refrain from vaginal intercourse on the days that a firming pattern is observed. So ano tong firming pattern? Saang firming pattern? So sa saliva to, guys. So kailangan tingnan yung saliva under a microscope. If you see a firming pattern, then you should refrain from vaginal intercourse. So ano ang reason behind this? Yung firming pattern is caused by your increase in estrogen. So sino ulit ang nag-i-increase, ang nagpo-produce ng estrogen? It's your follicles, no? So the moment na sobrang taas na ng estrogen level mo such that enough siya to cause firming pattern sa saliva nung female patient, then ibig sabihin fertile si female patient. Kasi nandun na siya sa point na sobrang taas ng estrogen niya, malapit nang mag-LH surge. Enough na yun to cause LH surge. Okay? So, ito yung mga means, no? So, as you can imagine, very tedious siya, no? Kasi kailangan mo pa ng microscope, titingnan mo pa yung laway mo, ganyan. So, very tedious. So, hindi din siya commonly employed na contraceptive method. But for me, it's enough for you to understand na yung firming pattern, this is caused by increase in the estradiol in your patient or estrogen in your patient. Okay? Okay. So other tier 3 methods are your spermicides and coitus interruptus or withdrawal method. Okay? So I don't think I need to explain this too further. Okay, so yun yung 3 tiers nyo. Again, yung tier 1, yun yung pinaka-effective. Yung last tier or yung tier 3 method, sila yung least effective. So we now move on to your emergency contraception. So madalas tinatawag sa ano. So how do you give your emergency contraceptive? So this is effective if the treatment begins within 72 hours after coitus. Pag na-miss yung 72 hours, pwede nyo pa rin siyang i-take up to 120 hours after intercourse or coitus. So we have contraception. First one is plan A. So you take one dose of levonorgestrel 1.5 milligrams orally. Or alternatively, pwede ka rin mag-take ng 0.70 for 2 doses. So 0.75 now, then after 12 hours, another 0.75 milligram tablet. Okay? So next or fail. So plan B, so ito yung mas commonly ginagamit namin sa emergency room. So we give a minimum of 100 micrograms of ethinyl estradiol and 0.5 milligrams of levonorgestrel. So 4 pills, i-explain ko mamaya kung bakit 4 pills yung piniprescribe namin in each of 2 doses 12 hours apart. So, ang commercially available is yung trust pills. Ito yung, ang preparation niya is ethinyl estradiol plus levonorgestrel. So, ang isang pill kasi ng trust pill mo is 30 micrograms. So, times 4, meron kang 120 micrograms. So, pasok siya, di ba? So, ang levonorgestrel naman niya is 125 micrograms or 0.125 milligrams. So times 4, pasok ulit siya na nasa 0.5 milligrams levonorgestrel, yung mabibigay mo na dose if you give 4 pills of your trust pills now, and then after another 12 hours, magbibigay ka ulit ng another dose ng 4 pills. Okay? So ano yung disadvantage nitong plan B? Nakakasuka siya, guys. At masakit siya sa ulo. So alternatively, you can insert copper IUD within 5 days from intercourse. So na-discuss natin to when we were discussing the intrauterine device as a form of contraception kanina, di ba? So these are your options for your emergency contraception. Okay, so let's move on to another chief complaint among your patients, which is increasing abdominal girth. So it goes without saying, kapag sinabi nila na lalaki tiyan, because of the pressure, occasionally, these patients also present to you with abdominal pain. Sometimes, dumadating sila sa emergency room, tapos sobrang sakit ng tiyan. Kapag ganon, in the presence of ovarian new growth, ang assessment namin sa kanila is ovarian new growth and complication. Okay? So let's discuss ano ba yung mga possible causes ng increasing abdominal girth among our patients. Okay, so again, I have another index case for you. So this is a 55-year-old G1P1 1001 who was referred for enlarging abdominal girth. She denies weight loss or anorexia, so wala siyang constitutional symptoms, And ito yung kanyang transvaginal ultrasound. Okay, there is massive ascites and occupying the abdominal pelvic area is a, 9 by 10 centimeter complex mass. So when you say complex, it's a combination of cystic and solid components that is predominantly solid. So that's a bad sign. Mamaya sasabihin ko kung bakit. For CA125 or antigen 125, that's a tumor marker, was noted to be 700 units per milliliter. So what is the appropriate surgical management for this? So do you have a diagnosis na in mind? So most likely, since this is a GYN patient, aside from GI pathology, siguro ito na yung next na commonly diagnosed assessment for us, no? So ito yung mga pertinent points sa patient. First of all, she's more on the elderly na siya, no? 55 years old. She has massive ascites. And look at the quality or the description of her mass. It's a 9 by 10 centimeter complex mass. And bad sign niya, as I told you a while ago, itong pagiging solid niya, no? And look at her CA125. It's elevated at 700 units per milliliter. No, so I don't remember all the exact values of CA125, but definitely this is elevated for her age, no? So likely she's already postmenopausal, and if it's greater than 35 units per ml in her age group, this is noted to be elevated. So ano ang appropriate management for this case? Okay, so most likely this is a case of ovarian new growth. So paano mo masasabi kung benign or malignant? So these are your clues. So note na hindi naman porke mas malaki sa 8 centimeters yung mass ay automatic malignant na siya. But more or less, habang lumalaki kasi yung mass, mas tumataas yung risk niya for malignancy. Okay, na-get? I hope that's clarified, no? So in terms of size, mas malaki yung mass, as mentioned, mas mataas yung chance na malignant. So greater than 8 centimeters, like in the case of our patient, medyo mas worry na tayo na malignant siya. Especially dun sa age ni patient, no? She's already 55 years old. So in terms of consistency or yung description ng mass, kapag benign, more of cystic sila, no solid components, or at least kung may solid component, minimal lang yung solid component, no septation. Kapag malignant, solid yung quality ng mass, mixed. Pag sabi mong mix yun nga, it's a mix of cystic and solid components, multilocular, multicystic, nodular or papillary, irregular walls, and septa. So in terms of laterality, most of the time yung mga malignant nyo bilateral. Pero hindi siya all the time, okay? Kasi pwede ka pa rin may bilateral ovarian new growth. Tapos yung parehas na ovary, pwede naman silang benign masses. So, hindi naman to all the time. Okay? So other features that will point you to a malignant ovarian new growth are ascites, peritoneal masses, because this could be a sign of metastasis to your peritoneum, and lymphadenopathy. Okay? So most of the time, ang spread ng ovarian cancer natin is via the lymphatic drainage. So, if you have lymphadenopathy, especially in your pelvic nodes and your para-aortic nodes, then you are suspicious for malignant ovarian new growth. Alright, so since ito yung impression ko sa patient, ovarian new growth, probably been malignant, ito yung aking plan for the patient. So, I will perform total hysterectomy with bilateral salpingo-oophorectomy with staging, okay? And since I am considering a malignant process here, I will refer pre-operatively to a gynecologist na oncologist as well, okay? So refer ka agad, hindi lang intra-op, dapat pre-operatively nagre-refer na tayo agad sa kanila. Alright, so ano ba yung complete surgical staging? So isa-isahin ko sa inyo guys kasi mag-a-assist na kayo ng mga gyne-onco procedure. So it's important for you to learn this kasi hindi lang siya sa ovarian new growth, probably malignant gagawin, pati rin sa mga ibang forms of gynecologic malignancies. Okay, so isa-isahin natin. So this is how you perform complete surgical staging. So, systematic abdominal exploration via a midline incision, no? So para bakit midline? So we prefer midline para in case mag-extend kami above the umbilicus for better exploration, mas magagawa namin siya if midline yung incision versus kung Halimbawa, fan and steel yung incision natin. Okay? So this is what we do, the peritoneal fluid cytology. And this is how you perform it. You do samplings of washings of 4 areas of peritoneal cavity. So sa diaphragm, right and left hemi-abdomen, even if there is tumor rupture or presence of tumor on the external capsule on clinical clinical disease stage 1. Okay? So mag-PPFC ka pa rin kahit may tumor rupture ka na on your assessment. Okay? Ayan. So at sa pelvis, ayan, sorry. So bale, 4 yung kukuhanan mo ng PFC or peritoneal fluid cytology: diaphragm, right and left hemi-abdomen, and pelvis. Okay? So, and then you do careful inspection and palpation of all surfaces. So, kaya siya exploratory laparotomy. You explore your abdominopelvic organ. So, after which you may biopsy and do resection of any suspicious lesions kung meron man, masses and adhesions. After which you remove the pathologic ovarian new growth. So, either right or left. Okay? Sabihin natin, for this patient, tanggalin natin tong right. Okay? So, yung right yung kanyang may ovarian new growth. Kasi, hindi ko ni-note kung right or left. Kasi sometimes hindi namin nakikita talaga yung laterality on imaging dahil sobrang laki ng mass. So, sabihin na lang natin for this patient, right yung tatanggalin ko. So, we perform that, removal of the pathologic ovarian new growth or pathologic adnexa. So, when you see removal of the primary ovarian or fallopian tumor, magkasama na yan ovary saka yung fallopian tube. So this is unilateral salpingo-oophorectomy. Okay? Then after which you perform total hysterectomy with unilateral salpingo-oophorectomy. So this is if the patient has already completed family size, tapos relatively old yung patient, pwede mo na talagang i-total hysterectomy yung patient. This will change kung halimbawa reproductive age woman, tapos may desire for future pregnancy, tapos yung tumor naman niya is not one with poor prognosis, ganyan, pwede kang USO lang for those patients. But for this patient, since she's postmenopausal already, has completed family size, we tend to perform total hysterectomy with unilateral salpingo-oophorectomy. So pagkatanggal mo na nitong right fallopian tube and ovary, you then remove the uterus and the contralateral fallopian tube with ovary. All right? Okay, so what else do we do in terms of staging? We perform infracolic omentectomy. Okay? So infracolic omentectomy is yung omentum mo sa ilalim nitong transverse colon. However, if you have gross omental involvement, like this patient, kunwari may cancer cell siya dito or mukhang may suspicious area siya sa omentum mo, you do infragastric omentectomy under the stomach. Yung lahat ng yon, bale parang kakalbuhin mo talaga siya, tatanggalin mo the entire omentum of the patient. Okay? Malinaw? Usually, we just perform IO, infracolic omentectomy, but in cases of gross involvement of your omentum, infragastric na siya. So, mas malaking portion ng omentum yung i-excise mo. And then, we perform random biopsies of normal peritoneal surfaces. Okay? So, 2 samples from each of the following: undersurface of the right hemidiaphragm, from the bladder reflection, so ito yung bladder mo, okay? From the cul-de-sac, which is behind your uterus, right and left paracolic recesses, so paracolic, so gilid nitong bowels, and then right and left pelvic side walls. Ayan, so yan yung mga, so marami kayong i-fix na samples, tapos magkaibang side pa yan, hindi mo pwedeng ipagsama yung right and left, since same naman po sila na right, paracolic areas, hindi, ihihiwalay mo siya right sa left. Okay? So, important yun sa mga gyne-onco later on pag titingnan nila yung histopathologic report ng patient mo. Okay? Okay, so then we proceed to systematic lymphadenectomy. So, itong lahat ng to guys, technically, pwedeng kami lang yung gumawa nito, no? General gyne. Pero, kapag kailangan mo nang mag-perform ng BLND or bilateral lymph node dissection, you already refer to your gyne-onco. Okay? So, sila yung nagpa-perform nito. So, we perform complete pelvic lymph node dissection and para-aortic lymph node sampling. So, So, anong difference ni dissection sa sampling? Sa dissection, tatanggalin mo talaga lahat ng lymph nodes na makikita mo dun sa border kung saan sila dapat magtanggal. So, ang usual na tinatanggalan nila ng lymph nodes is your external iliac artery. So, ito yung common iliac, diba? This is the internal, this is the external iliac artery. So, lahat ng lymph nodes dyan, within the anatomic borders na prescribed by their operative technique, tatanggalin talaga nila kahit hindi siya grossly involved. So, ang sampling naman, from the name itself, sampling, hindi mo naman kailangan tanggalin lahat ng para-aortic lymph nodes there. Sometimes they forgo this if in certain cases, kapag wala namang gross involvement yung lymph nodes, no? Pero most of the time, they get samples from your para-aortic lymph nodes also. So, dito sila kukuha sa area na to. Okay? So, again, kapag mag-fix kayo ng specimen, hiwalay si external iliac lymph node. Sorry, I missed this out. No? May isa pa silang kinukuhanan dito over the obturator nerve. Okay? So, yung lymph nodes din na mahahanap nila dito, they also do lymph node dissection. So parang pag in terms of lymph node sampling and dissection, meron kang 1 to 5 specimens dapat. Kasi right external iliac lymph nodes and right obturator lymph nodes, tapos yung left din, plus yung para-aortic. Okay? So marami talagang specimens when you do complete staging in your patient. For mucinous tumors or other types of tumors with the appendix grossly involved, we also perform appendectomy. Bakit? Anong ibig sabihin ng mucinous? Ibig sabihin, when you cut your specimen, mucin yung lalabas, parang sipon. Okay? Yun yung quality ng fluid inside your ovarian new growth. Why do we do that? Because sometimes they are actually metastatic from a primary appendiceal carcinoma. Okay? So that occasionally happens. So we also perform appendectomy for cases of mucinous na tumors that are malignant looking intraoperatively. Okay. So now this is your complete staging for the patient. This is the complete procedure. Okay. So if ipa-spell out sa iyo ng resident to, this is how you will write it. Okay. Exploratory laparotomy, peritoneal fluid cytology, unilateral salpingo-oophorectomy. So sa patient natin, kunwari, right salpingo-oophorectomy, total hysterectomy with left salpingo-oophorectomy, intracolic omentectomy, bilateral lymph node dissection, para-aortic lymph node sampling. So kung mukha siyang mucinous on cut section, you also perform appendectomy. Okay? I hope that's clear. All right, so we have another case of a patient presenting with increasing abdominal girth. Lumalaki po yung tiyan ko, Doc. All right, so this is a younger patient. She's an 18-year-old nulligravid with increasing abdominal girth with occasional pelvic heaviness. There are no other associated symptoms. So this is her ultrasound picture, no? So there is a 10 by 10 centimeter cystic abdominopelvic mass with echogenic lines and dots. Ayan. So parang may dot, ito yung dots, tapos may mga lines, and a 1 centimeter and 2 centimeter solid hyperechoic focus. Okay, so maliit lang naman siya na solid area. So ano yung consideration mo for this case? Okay, so at this point, I want to orient you na regarding the different types of ovarian new growths or ovarian cancers. So as usual, like any other parts of your body, your mass could either be benign or malignant. Okay, so I will discuss both. So these are the general types of your ovarian tumors. All right. So yung pinaka-common is your epithelial. Okay. So the way I remember these types, iniisip ko yung different parts of the ovary kung saan siya pwedeng mag-arise. Okay, so I hope you will appreciate the color coding that I did for this slide. No? So the first type, which is the most common, is your epithelial tumors. Okay, so epithelial, kung papansinin niyo, orange din siya, diba? So they arise from the epithelium surrounding your ovary. So the most common types of your epithelial tumors are your serous and your mucinous. Other types are your Brenner tumors. And these are the other lesser known types. Hindi man lesser known, rarer, okay? Mas rare na types, endometrioid and clear cell. So bakit naka-highlight si endometrioid and clear cell? Because these two types of tumors are associated with your pelvic endometriosis. So if you have a patient na may history of pelvic endometriosis, or yung symptomatology niya nung nagre-regla pa lang siya, may cyclic pelvic pain, may dyspareunia, infertile, etc. Kung consistent siya with pelvic endometriosis, tapos eventually nagkaroon siya ng ovarian new growth, be worried because she could be having one of these two tumors, no? Endometrioid na adenocarcinoma or clear cell carcinoma. So clear cell, ayaw natin yan because this is a very aggressive form of ovarian cancer. So, si serous, mucinous, si Brenner, meron silang benign and malignant counterparts. Si serous and mucinous, diba, sila yung serous cystadenoma. Pag cancer, serous cystadenocarcinoma. Okay? So, ano yung pathophysiology behind your epithelial tumors, especially your cancerous type? This is caused by frequent breaks in the epithelium, okay? So frequent, which is usually caused by frequent ovulation, okay? So therefore, if alam mo yun, alam mo na ang protective against cancer are those that will prevent ovulation. Naget? So kapag halimbawa, ikaw ay nagbuntis multiple times in your life, that is protective against ovarian cancer. Why? Because habang hindi ka buntis and during the time na naglalactate ka, if you're doing lactation amenorrhea method most especially, hindi ka nag-ovulate nun. So longer yung periods mo na hindi nag-ovulate, longer yung time na hindi na-injure ang iyong epithelium. Okay, so that's one example. So if you take your pills, your OCPs, diba, either progestin-only pill or your combined oral contraceptive pills, that is also considered protective. Why? Because, di ba, ang primary mechanism of action ng iyong pills is to inhibit ovulation. So, lahat ng mga conditions, so ganun nyo intindihin yung mga protective factors and risk factors, ha? Intindihin nyo yung main theme ng mga risk factors or ng protective factors. So, bakit siya nagiging protective? Bakit siya nagiging risk factor? Okay? So, in the same light, ano yung mga risk factors mo? So, kapag ikaw ay parating nag-ovulate, so early ka nag-ovulate, early ka nag-start ng menarche, or late ka nag-menopause, diba? So those are possible risk factors kasi or pagiging naligavid kasi never kang nagkaroon ng period na hindi ka nag-ovulate. So yun, parating nag-violate yung epithelium mo, parati siyang nagkaka-injury. So you are more at risk for having these epithelial tumors of your ovaries. Okay? Na-get? So ano yung isa pang pwedeng pagmulan ng ovarian new growth? So the next common na family of ovarian new growths are your germ cell tumors. Germ cell ay galing dito kay gametes, di ba? Sa oocyte mo. So yung mga germ cell, when you say germ cell, sila di ba yung eventually nag-form ng mga germ cell layers? So what will eventually become the embryo, yun yung pinagmulan ng germ cell tumors. So syempre, saan siya manggagaling? From your oocyte. So ito yung mga tumors under your germ cell tumors. This germinoma, this is the most common malignant germ cell tumor. Yolk sac tumor, choriocarcinoma, your teratoma, and your embryonal carcinoma. Okay? So mamaya, siguro later on sa next ko na lecture, which is on the pathology na integration ng OB topics, I will discuss each one, no? Isa-isa, papakitaan ko kayo ng histology, saka ng gross pictures. But for now, enough na sa akin malaman na alam nyo kung sino yung mga under germ cell tumors and kung ano yung mga corresponding na tumor markers, okay? Kasi in terms of presentation, in terms of age group, halos magkakaparehas lang. So, yung mga nakikitaan natin ng germ cell tumors. So, saan mo usually nakikita si germ cell tumors? Sa young patients, okay? Kaya mamaya, papakita ko sa inyo yung guidelines namin, bakit nag-order kami ng extra tumor markers for patients with complex mass. Kahit yung ultrasound nila, they present very similarly, no? Complex mass, etc. Except for this teratoma, may ano siya, mamaya papakita ko sa inyo yung isang picture ng ultrasound na distinguishing teratoma from the other germ cell tumors. Okay, so si teratoma, just like the other, just like your epithelial tumors, meron siyang malignant and benign counterpart. So yung benign na teratoma is called mature cystic. So ibig sabihin ng mature cystic teratoma, lahat ng germlines na makikita mo sa iyong histology ng teratoma ay mature. Okay, they are well differentiated. Meron naman tayong tinatawag na immature teratoma. Pag immature teratoma, that's considered a malignant tumor, okay? So anong makikita mo sa immature teratoma? You will see neural tissues, okay? So yun yung isa sa mga hinahanap mo if you're suspecting immature cystic teratoma. Alright? So, aside from may hindi pa ba tayo na mention, meron pa, di ba, itong pink, yung mga follicles around. So, at saka itong lighter orange. So, ano yung mga pwedeng mag-arise na tumors from your follicle? Yan, sila yung sex-cord tumors. So, there are two sex-cord tumors common. These are your granulosa cell tumor and your Sertoli Leydig tumors. So these are both malignant, okay? The granulosa cell, ang pinuproduce niya is estrogen and inhibin. So, si granulosa cell, dahil nagproduce siya ng inhibin, ano ang kanya, ng estrogen rather. So, doon tayo kay estrogen. Ano ang sa tingin yung symptoms ng merong may granulosa cell tumor? So, kapag meron kang granulosa cell tumor at ikaw ay prepubertal, meaning bata ka, magkakaroon ka ng precocious puberty. Okay? So mag-bleed ka, magkakaroon ka ng breast prior to the start of menarche. Okay? That's because of your estrogen. Si Sertoli Leydig naman, Sertoli will produce your testosterone. So, kung si granulosa cell is precocious puberty, si Sertoli Leydig naman, this will present with virilizing symptoms. So, ano yung mga examples ng virilizing symptoms? Hirsutism, you can have lowering of your voice, basta they are all masculinizing signs and symptoms, okay? So, another one pala regarding granulosa cell. So, as I mentioned, precocious puberty kapag meron kang bata na may granulosa cell tumor. Okay? So, alam niyo na ha, kapag meron kang bata na may abdominopelvic mass and one of her presentation is precocious puberty, like she's having spotting, nagde-develop siya ng breast, ang iisipin mo, she could be a case of granulosa cell tumor. Okay? Kapag matanda naman, like postmenopausal, ano yung presentation niya? So, ang presentation niya sa matatanda is postmenopausal bleeding. So, ganun pa rin, no? May bleeding factor yung granulosa cell tumor, whether sa bata or sa matanda. Now, finally, this is the last tumor. Hindi pala finally, may isa pa pala akong i-emphasize na kind ng tumor that you will see in your ovary. So ito yung lighter orange. No? From your stroma naman, you can have your fibroma. So fibroma, kapag binuksan mo siya on cut section, mukha siyang leiomyoma. Okay? Even on ultrasound, na pagkakamalan to na subserous myoma. No? So si fibroma comes from the stroma of your ovary. Okay? So most of the time, it's benign, but this is the one benign tumor, your fibroma, that will present with ascites, okay? Because of peritoneal irritation. So later on, I will also teach you that sa pathology correlates ng OB. So one other kind of tumor that I want to share with you is your Krukenberg tumor or your metastatic tumors. Most of the time, this is bilateral, okay? Very rarely ka makakita ng metastatic to the ovary na unilateral. So, it will present as bilateral na solid mass and ang history ng patient, meron din siyang history of GIT or gastrointestinal tumors. So, kapag nakita mo yun sa patient mo, ang iisipin mo, possibly, this is a metastatic tumor very rare na dalawa yung primary tumors mo, no? So kapag meron kang GIT tumor like colon CA, tapos nag-present siya with bilateral new growth, pwedeng yung nakikita na bilateral new growth ay metastatic from the GI, primary GI tumor. So we call that Krukenberg, okay? Yun yung special name natin for that kind of ovarian new growth. All right. Now we move on to the tumor marker. So again, at this point, ito lang muna yung mga gusto kong ma-memorize niyo. Okay? So what do we request for? For epithelial tumors, we request for cancer antigen 125. Now, yung mucinous tumors kasi, they don't always present with elevated CA125. So we request another cancer antigen, which is your 19-9. For your dysgerminomas, we request for LDH. Your yolk sac tumor, we request for alpha-fetal protein or your AFP. And for choriocarcinoma, of course, because these come from your syncytial trophoblast, we request for beta-HCG. Guys, huwag kayong malilito about choriocarcinoma ha, kasi may dalawa din siyang kind. May gestational kind, yun yung mga nasa gestational trophoblastic disease. Meron ding mas rare na non-gestational choriocarcinoma. So yun ay inherently nagpo-produce sila ng beta-HCG without having been coming from an H mole na naging invasive mole, etc. Okay? So last is your granulosa cell tumor, for which we request inhibin, no? So hindi yung estrogen yung pinapatumor marker natin kasi 'di ba very variable siya sa women. No, so yung inhibin yung i-request natin na tumor marker for your granulosa cell tumor. Now, we also request for CEA, especially if we co-manage with other services and if you have a high index of suspicion for GI pathologies. So for your Krukenberg, we request your CEA. Okay? So yan yung isa natin pang nire-request. But usually, itong mga to hanggang dito kay inhibin, yung nire-request natin. Okay, so lahat ba, Doktora, left and right, mag-request kami. So lahat pala ng ovarian new growth, orderan ko nila ng AFP, LDH, beta-HCG, etc. Hindi naman lahat, okay? So ano yung age na kailangan nating mag-request ng tumor marker? And ano dapat yung quality or consistency ng ovarian new growth mo? So we only request for LDH, AFP, beta-HCG. This is in our local guidelines. If the woman is under age 40 and she presents with a complex ovarian mass. This is because of the high likelihood of germ cell tumors. Now, if she presents with abnormal uterine bleeding, you may also request for inhibin, okay? Because she may be having a granulosa cell tumor, okay? She may have granulosa cell tumor, all right? Okay, so let's go back to our patient. So eventually, since malaki yung mass, no, 10 by 10 centimeters, this patient underwent laparoscopic surgery and you performed oophorecystectomy. So again, guys, kindly save the ovary for your young patient as much as possible. If you're not considering malignancy, hopefully oophorecystectomy lang yung gagawin ng gynecologist na makaka-duty nyo. Alright, so on cut section, ito yung nakita nyo, no? Unilocular na cystic mass, may hair and sebum within. So, what is this case? We are dealing with a case of mature cystic teratoma. So, ito yung mga well-differentiated na germ cell tissues, no? You have hair, tissue, sometimes may teeth pa yan. So, itong mga stipplings na to, yung dot and dash na yan, na very variable yung itsura sa loob ng iyong cyst, yan yung nire-represent ng sebum sa kanong hair. Okay? So, yan siya. Yan yung corresponding structure niya on gross picture ng ovarian new growth. And remember, di ba, I told you meron siyang 2 centimeter na solid nodule. So, hindi naman kami suspicious for malignancy, especially kung ganito yung picture ng cyst, no? Because that is what you call a Rokitansky nodule. Okay? This is a nodule found in your mature cystic teratomas, and it represents a focal area of calcification. So, pwedeng may bone within yan, may piece dyan, ganyan. So, yan yung Rokitansky nodule na tinatawag, okay? So, that is seen in your mature cystic teratomas or your dermoid cyst. Alright. Now, let's move on. This is another case of increasing abdominal girth. So, tingnan natin. So, meron na tayong matanda, meron na tayong nasa reproductive age. Now, we'll look at this case. We have a young patient, a pre-pubertal patient, no? Supposedly pre-pubertal. A 5-year-old was brought to your clinic due to intermittent peri-umbilical pain for the past 4 months. She has no headache or blurring of vision, so take note of this. This is a pertinent negative, kumbaga. And upon probing, her mother reported breast enlargement and occasional spotting. So ma-alert ka na yan, 5 years old lang to, may breast enlargement, tapos parang nagme-mens na siya. On ultrasound, the patient had a 6 by 4 centimeter complex abdominopelvic mass. Again, when you see complex, it's a combination of solid and cystic components. And now, we are asking you which is the most likely diagnosis. So, na-mention ko na to kanina, ang tumor marker for this is inhibin. Most likely, you are dealing with a case of blank. Okay, so anyway, first of all, this patient is presenting to you with precocious puberty. So, when do you investigate for precocious puberty? So these are the instances when you have to investigate if the patient is less than 6 years old with breast or pubic hair. So either yan, no? So either nag-telarc siya or nag-adrenarch siya. And then, pwede ka rin mag-investigate, warranted din, if you have both of the features pag less than 8 years old. Pag or lang ito, guys, we tend to just observe the patient, okay? Pag ortho, hindi kami nag-investigate. Kailangan dalawang features yung nakikita mo sa patient, both the breast and the pubic hair, if you will investigate at less than 8 years old. However, like in the case of our patient, less than 6 years old siya, breast lang yung present sa kanya, hindi na mention kung may pubic hair, still, you will investigate for causes of precocious puberty, okay? And another instance when you will investigate for precocious puberty, if you have an increased risk for intracranial pathology, like for example, you have a strong family history or you have a pertinent medical history na nasabihan yung patient na meron siyang intracranial pathology nung baby pa lang siya, and there is rapid pubertal progression, then you will investigate for a cause of your precocious puberty. So, review lang natin kung ano ba dapat normally yung puberty. How does one patient undergo puberty? So, ito yung typical age na makikita mo yung mga developments during puberty. So, meron kaming, what do you call it? Hindi siya mnemonic pero one way to memorize yung mga events ng puberty is up, down, up, down. So, anong ibig sabihin ko noon? So, the first event of your puberty is your telarc, okay? So, that is breast involvement, so up. And then, after that, you go down because you will see your pubic hair. There will be pubic hair and kasama na dito yung axillary hair. Essentially, nag-adrenarch na sila, okay? So, this is facilitated by your androgens. So, again, up, down, up yung next because may maximal growth. Height, this is height, okay, maximal growth in terms of height dun sa mga patients na nagpo-puberty. So, dito na yung growth spurt. And after your growth spurt, you expect your menarche, so down. So, linalabas na yung blood. Yan. So, that will be the last event seen in your puberty. And that is, like your breast, that is mediated or facilitated by your estradiol hormone. O, ano ba yung cause mo ng precocious puberty? So again, babalik tayo sa HPO axis. Diba? Sabi ko sa inyo, very important yung concept na yan because it could either be GnRH dependent or GnRH independent. Kapag sinabi mong GnRH dependent, this is coming from a central cause because saan galing si GnRH? It comes from the start of your HPO axis, which is higher up in the hypothalamus. Okay, so what are your examples of GnRH dependent na causes of precocious puberty? It could be idiopathic. It could be coming from a CNS lesion. That's why I noted a while ago sa history ng patient, wala siya ng blurring of vision, wala siyang any signs na meron siyang increasing intracranial pressure. Okay? Primary hypothyroidism because as I mentioned, doon sa mga previous parts ng lecture ko, di ba? Hypothyroidism, low FT4 levels will cause inhibition of your GnRH. So yung cascade mo sa HPO axis will be inhibited as a result. Next is your GnRH independent causes. So mas peripheral tong cause na to. So an example is having an ovarian new growth, particularly if it's the granulosa cell tumor type. Okay? Because this is a hormonally active tumor that produces estrogen. So that will cause the precocious puberty in patients with ovarian new growth. Okay? With granulosa cell tumor. Pwede rin siyang adrenocortical tumor or any problem in your adrenocortical system because this will increase the production of androgens and your androgens will eventually be converted to your estrogen. So, magpe-precocious puberty sila. Okay, one other cause of your GnRH-independent precocious puberty, ito, take note of this, guys, kasi this is a board exam question, no? Your McCune-Albright syndrome. So, ano yung McCune-Albright syndrome? This has a triad. So, ito yung triad ng McCune-Albright. Fibrous dysplasia, Café-Olay spot, and precocious puberty. Okay? So, ano bang meron sa McCune-Albright syndrome? This is a genetic disorder wherein yung CAMP mo or your cyclic adenosine monophosphate is always on. Okay? Nasa on mode siya parate. So, in effect, ito yung mga end result niya sa mga batang may McCune-Albright syndrome. So, kapag meron kang patient na nagpe-present with spotting, precocious puberty, tapos meron siyang frequent fractures, and if you look at her skin, meron siyang mga café-olay spots, ito yung iisipin mo, no? McCune-Albright syndrome. Now, the last cause na ipipresent ko sa inyo under GnRH-independent causes of precocious puberty is your iatrogenic causes. So, ano yung sabihin ng iatrogenic? So, pwedeng nagbigay ka ng topical estrogen sa patient mo for one reason or another. So, this will cause premature stimulation of your HPO axis. Okay? So, particularly dun tayo sa O, no? That part of your HPO axis. So, because of the exogenous estrogens, pwede kang magkaroon ng precocious puberty. Alright? So, malinaw tayo dyan. So, dito sa patient natin, because of all these things, no? So, wala siya nitong pertinent negative to. Wala, mukhang hindi naman primary CNS lesion yung sa patient natin. And meron siyang signs of precocious puberty. Plus, in the presence of an abdominopelvic mass, which is likely ovarian in origin, you could be dealing with a case of granulosa cell tumor. Again, what's our tumor marker for your granulosa cell tumor? It's your inhibin. Ayan. So in the young, this presents with precocious puberty, and in the old patients, and the older patients, especially your postmenopausal patients, they will present with postmenopausal bleeding. Okay, so just to recap, ito na yung mga nalaman natin, ito na yung mga na-discuss natin na chief complaint/concern ng patients. We'll now move on to the last, na tayo sa end ng timeline. Doon na tayo sa menopausal years or postmenopausal years ng patient. Okay? So under menopause, I'll be discussing two of the common symptoms that the patient will present to you with. Before I discuss with you yung chief complaints nila, doon muna tayo sa physiology behind menopause. So what happens when you're menopause? So first, I'll give you a board exam type question. You have a 49-year-old patient who consulted due to dyspareunia. She had her menses 18 months prior to her consultation. So take note of the time component, 18 months. She also complained of hot flushes and frequent mood swings, which is true regarding her hormonal milieu. Okay? So first of all, kung patient ba na to, menopause na? Most definitely. Okay? So essentially, tanong ko sa inyo, ano ang makikita mo sa kanya? Kung ipapa-hormonal assay mo siya, ano yung makikita mong picture? Alright, so she's considered menopause because there was already permanent cessation of menstruation for 12 months due to loss of ovarian follicular activity. So remember, si patient natin, meron na siyang loss of menses. So loss of menses for the past 18 months, di ba? Yun daw yung last menses niya. On top of that, meron din siyang other symptoms of menopausal patients. So, ano ba nangyayari when you're menopause? So when you're menopause already, athletic na yung follicles mo. So when there is aphasia or atrophy of your follicles, you have decreased amounts of these hormones, which are all produced by your follicles, di ba? Your estrogen, your inhibin, testosterone, and your AMH, lahat yan bababa. So, because mababa itong mga hormones na to, especially your estrogen and inhibin, what happens is walang nag-negative feedback to your anterior pituitary, such that tataas yung SSH mo. So this is a hallmark of your menopausal transition, no? Kapag mataas na yung SSH mo and mababa yung estrogen and your inhibin. Okay? Okay. So just some terminologies, no, para hindi kayo malito. So when you say perimenopause, this refers to the years prior to menopause. So this encompasses the change from normal ovulatory cycles to cessation of menses. So usually yung mga patients na who come to us with irregular menses already, they're already becoming anovulatory, no, because of your decreasing amount of follicles already. So because of this, they either have skipped periods or longer intervals, so 40 to 60 days yung average, which is the hallmark of this period, no, your perimenopausal period. So this is your menopausal transition. Now, when you see climacteric, this now refers to the period of time when a woman passes from reproductive age to non-reproductive stage. So, ano yung ine-encompass ni climacteric? Mas mahabang time period because it includes this one, the perimenopause, the menopause, and the postmenopausal years. So, mas mahaba si climacteric. Okay? So, ano yung mga signs and symptoms? So, si patient, di ba, this is her complaint. Hot flushes or flashes. They're the same thing. So, this is a sudden sensation na naiinitan sila. Okay? So, pag halimbawa naiinitan yung mga, ganun yung mga matatanda, no, they always bring with them their abanico, their fans, or they have their electric fans with them na mini, because this is the hallmark of female climacteric. So, bakit nagkakaroon ng hot flushes or flashes? So, this is because decrease in estrogen changes the thermoregulation in your hypothalamus. So, ito yung response ng katawan to the decrease in estrogen. So, these are the other signs and symptoms of your menopausal patients. So, kapag they undergo these symptoms, guys, huwag nyo naman na silang lokohin, no? Kasi hindi biro mag-menopause. Imagine from a period na okay yung estrogen levels mo, suddenly i-withdraw yun sa'yo. So, ano ba kasi yung point ng estrogen sa katawan ng mga babae? So, it promotes good vasculature in the pelvic organ. So, in effect, it also causes magandang connective tissues, no? So, nami-maintain yung collagen. So, kapag ikaw ay wala ng estrogen in your body, which happens during your menopausal years or your menopausal transition, you could have dryness, itchiness, burning sensation, which could result to dyspareunia or painful intercourse, no? Kasi yung vagina mo is nawawala na yan ng lugay, hindi na ganun ka well vascularized, tapos yung mga connective tissues mo, nababawasan na rin yan ng quality during the menopausal years, okay? So yung mga patients na yon, nagbibigay kami sa kanila ng vaginal estrogen to help address these symptoms. So they could have vulvovaginal symptoms, pelvic organ prolapse, because why? Nababawasan na yung connective tissue, yung integrity ng connective tissue. Therefore, yung mga ligaments nila, nag-feel na yan during the menopausal years. So, ang effect, nagpe-pelvic organ prolapse sila. So, they can also have sexual dysfunction from this, decline in cognitive function. Ang masama dito, there could be elevation of total cholesterol, and there is also loss of trabecular bone, more than cortical bone, although both to nawawala during the menopausal years or your postmenopausal years. That's why these patients, we usually work them up or we screen them for osteoporosis, diba? Okay. So, regarding this patient, ano ang true regarding her hormonal milieu? She's already postmenopausal. Is it decreased FSH? So we know that this is false. Dapat increase na to kasi wala nang nagne-negative feedback sa kanya. Increase AMH, increase inhibin. So again, itong dalawang to false. Therefore, ang tama lang is the letter B, no? Decrease estrogen. The rest ay magdi-decrease din, including your testosterone. So that's what you see in patients who are already postmenopausal. All right? Okay. So one of the chief complaints na maririnig nyo sa mga patients sa postmenopausal, so alam na nga nila no, na hindi na talaga sila dapat mag-bleed. And then, they suddenly arrive at your clinic telling you na nag-spotting sila. So kapag ganon, warranted na investigate natin yung cause ng bleeding nila. So these are your differential diagnosis for postmenopausal bleeding. As you can see, endometrial atrophy causes most of the cases of postmenopausal bleeding. However, note na pwede rin siyang due to endometrial cancer. That is why, kahit most likely endometrial atrophy ang cause ng postmenopausal bleeding, kailangan pa rin natin silang i-work up at i-investigate, okay? To rule out if there is any underlying pathology, particularly endometrial cancer. So again, bakit kayo nagbi-bleed with endometrial atrophy? So nagkikis-kis na kasi yung anterior and posterior myometrium mo. So when that happens, it could occasionally cause spotting in patients who are already postmenopausal, okay? Okay, so we'll go to our first index case under postmenopausal bleeding. We have a 65-year-old nulligravid. So take note of her OB score. She's nulligravid and she's complaining of postmenopausal bleeding. Transvaginal ultrasound, a thickened endometrium of 7 millimeters. What is your next step of management? So bakit nasabing thickened tong 7 millimeters? Ano po ba ang thickened, doktora, sa age group na yan? So 4 millimeters or less is indicative of low risk of malignancy. Therefore, greater than 4 millimeters in the postmenopausal age group, that's considered thickened and it warrants investigation. Okay? So for this patient, we perform endometrial biopsy. So that is the next step in your management. Doktora, pag ganito po ba, pwede ko itong i-label na AUB? Kasi po, di ba, parang AUBM po to, di ba? Kung yun po yung nirule out nyo, yung mga malignancy, hyperplasia, no. Kapag postmenopausal na yung patient, hindi mo na yan i-label as abnormal uterine bleeding. We reserve the abnormal uterine bleeding until siguro sa mga perimenopause. Pero pag postmenopausal na sila, we have a special denotation for them. No, we call them postmenopausal bleeding instead of labeling them as abnormal uterine bleeding. Okay? Malinaw? So kapag 65 years old na yun, huwag na silang i-label na AUB. Okay? Postmenopausal bleeding na yung ilalagay nyo sa assessment and sa history taking nyo. Alright, so okay, performed endometrial biopsy and this was the result. Okay? Endometrial adenocarcinoma, endometrioid type, FIGO grade 1. So yan yung full na histologic diagnosis ng iyong endometrial pathology. Okay? So this patient is a case of endometrial cancer. So itong patient ba natin, meron siyang risk factor for endometrial cancer? We'll see. Okay. So, ang main theme ng risk factors mo under the cause endometrial cancer is unopposed estrogen stimulation of the endometrium. So, kailan to nangyayari? For example, nag-menopause ka after 52 years old. So, ibig sabihin, incessantly, nagre-regla ka lang, so incessantly na-expose ka to estrogen, then you have a higher risk for developing endometrial cancer. Okay? Before sa local guidelines natin, kapag you're still regularly menstruating by the age of 52, that already warrants endometrial biopsy. So ngayon, wala naman na yun sa guidelines na yung still regularly menstruating at 52, do endometrial biopsy. Pero still, if greater than 45 years old ka and you're presenting with abnormal bleeding, ayan, binabiopsy namin yan to rule out an underlying endometrial pathology, particularly endometrial cancer. So obesity. How can obesity cause endometrial cancer? No? So your fat cells kasi, it contains aromatase, which converts your androgens to your estrogens. So mataas yung circulating estrogens in these patients, and this causes estrogen stimulation through your endometrium. So ano pa yung isang risk factor which is present in our patient, no? She is nulliparous. So what happens kasi when you're nulliparous is continuously ka lang nagre-regular, continuously ka nag-undergo ng ovulatory cycles mo, di ba? So when that happens, wala kang periods of time na kagaya ng sa mga buntis na hindi sila exposed to high estrogen levels. Okay? Na-get niyo yun? So since never silang nabuntis, wala silang break from estrogen stimulation during their cycle. So, sila yung mas likely na mag-develop ng endometrial cancer. I hope that's clear. So these are just some of the risk factors for your endometrial cancer. So ano naman yung mga protective mo? So syempre, if menopause at a later age, menopause at an earlier age will be protective for endometrial cancer. Multiparity, bilang nulliparity is a risk factor. I already explained why this is protective. Itong use of OCT, this is protective against endometrial cancer kasi na-maintain niya yung thinned out endometrium, no? So hindi siya kumakapal, never siyang nagkakaroon ng chance maging hyperplastic, which could eventually become carcinomatous in the future, okay? So, or cancerous in the future. So, yun yung role ng progestin and your combined oral contraceptive pills in terms of being protective against endometrial cancer. So, I have a question. Ito ay, ano yung ironic na risk factor, na protective against endometrial cancer? So, itong factor na to is also protective against preeclampsia. Okay? So, ironically, yung smoking history, that is protective against endometrial carcinoma. So, sabi nila, yung mga smokers, ang sinasabi nilang pathophysiology or pathogenesis behind it is hindi kasi maganda yung endometrium nung mga smokers, no, because of the hypoxia. So, hindi siya nagpo-proliferate. Therefore, hindi sila nagde-develop ng endometrial cancer. So, yun yung mga proposed mechanism or protective mechanism ng smoking against endometrial cancer. But still, that doesn't, excuse you from smoking. Marami kang ibang kalaban if you smoke. So, hindi porke protective siya against preeclampsia and endometrial cancer, mag-smoke na kayo. Alright? So, that's interesting lang to note. No? Ironic siya na risk, a protective factor against this type of cancer. Okay. Now, di ba, I mentioned kanina nung sinabi ko yung endometrial biopsy result, meron siyang grade. May FIGO grading na na-mention doon. So, anong ibig sabihin ng FIGO grading? It's graded from grade 1 to 3, from well-differentiated to poorly differentiated. So, grade 1 yung pinaka-gusto mo, grade 3 yung pinaka-ayaw mo, and ang basis natin for this is the percentage or the ratio or the proportion of your solid components. Mas maraming solid components, mas pangit. Okay? So they say that histologic grade is the most important prognostic factor for endometrial cancer. So tinatanong din po occasionally sa boards nyo. This came from Blueprint. Okay? So what are your other prognostic factors? These are your age, depth of myometrial invasion, histologic type, surgical stage, peritoneal cytology involvement, tumor size, lymphovascular invasion, and pelvic node metastasis. Pero despite all these, ang pinaka-important daw na tinitingnan is kung ano yung histologic grade ng patient. Okay, meron tayong mga kinds ng endometrial cases na either type 1 or type 2. So anong ibig sabihin ng type 1, type 2? Alin yung mas gusto mo? Mas gusto mo si type 1. Okay? Si type 1, bakit? So, ang prototype na histologic picture niya is endometrioid carcinoma. Si type 2, mas pangit na serous papillary. Okay? Mas pangit yung prognosis nito. Yung typical patient mo sa type 1 is yung mukhang nag-undergo ng unopposed estrogen stimulation. Okay? So, kumbaga yung dinescribe ko kanina na mga risk factors, etc. Ito siya. Meron siyang type 1 na endometrial CA. Okay? So, ito yung typical picture ng endometrial CA patient. So, they're in the peri or early postmenopause, hyperplastic background yung endometrium nila, meaning possibly itong patient na to prior to having endometrial cancer, merong hyperplastic changes na yung kanyang endometrium. Low grade usually yung kanilang histologic type. And this one is estrogen dependent, and the estrogen receptors are positive. So mas gusto natin to. They have better prognosis compared to your type 2. So yung mga type 2 nyo, ito kasi yung sporadic, no? So ibig sabihin, meron kang gene mutation, may pangat ka ng mutation, kaya ka nagkaroon ng type 2. So very unpredictable yung mga type 2 patients natin. Compared to your type 1, na alam mo lang na dahil siya sa estrogen dependence or sa unopposed estrogen stimulation. So, mas madali namin itong ma-address actually. So, ang pangit sa type 2 is they typically come from an atrophic background ng endometrium. So, instead of the hyperplastic, yung kumakapal na lining ng matres, atrophic yung endometrium na pinanggalingan nitong cancer na to. They are usually high grade in terms of histologic type. They're non-estrogen dependent and therefore they have a poorer prognosis. So between the two of them, ang mas ayaw mo na type ng endometrial cancer is this picture, no? Si type 2 na endom-CA. Mas gusto mo si type 1. Now, how do we address endom-CA? So anong stage ni patient? Ano ba ang stage ng endometrial cancer? Ang endometrial cancer is surgico-pathologically staged. Meaning, kailangan mong operahan yung patient at kailangan makita mo yung histopath result bago ka magsabi ng final stage mo. Okay? So sa patient na to, ito lang yung diagnosis ko sa kanya. Endometrial adenocarcinoma, endometrioid type, SIGO grade 1, confined to the corpus. So wala pa ako masabi sa kanya na stage ng patient because pag nagtanong siya, Doktor, ano pong stage ko? Pwede ka magsabi ng likely stage niya pero wala ka pang masasabi at this point kasi kailangan maoperahan mo siya. Kailangan mabuksan mo yung specimen and magkaroon ng exploratory laparoscopy. Kailangan ma-explore mo yung peritoneum niya para masabi mo kung ano yung intraoperative stage ni patient. Okay, so ano ba ang treatment? Ano ang surgical plan mo for patients with endom-CA? Ito ang full na plan mo for the patient. So same lang tayo ng lymph node dissection sa iyong ovarian new growth, no? Bilateral lymph node dissection or BLND, plus minus para aortic lymph node sampling. Alright? So the full surgical plan for this patient is exploratory laparotomy, peritoneal fluid cytology. So same lang din to nung sa ovarian new growth na malignant, extrafascial hysterectomy with bilateral salpingo-oophorectomy and your lymph node dissection, plus minus para aortic lymph node sampling. So, Doktora, anong difference po ng typical total hysterectomy with extrafascial hysterectomy? This is your uterus, no? And ito yung cervix ninyo. This is your vagina, your bladder. And then, ang important na structure dito na manote is your pubocervical fascia. Okay? Pag sinabi mong subtotal hysterectomy, hindi namin sinasama si cervix. Okay? Sa subtotal hysterectomy. Pag sinabi mong total hysterectomy, kasama na nun si cervix. Pag sinabi mong extrafascial hysterectomy, we dissect the pubocervical fascia. Ibig sabihin, pag tinanggal mo yung uterus, dapat kasama mo si pubocervical fascia. Okay? Yun talaga ang distinguishing na characteristic ng extrafascial versus your total hysterectomy. Kailangan kasama si pubocervical fascia mo kapag nag-remove ka ng uterus. Now, I'll orient you na at this point sa mga possibly makita nyong structures when you open your uterus, no? Kapag nag-assist kayo sa mga gyne-onco, ganyan, or sa gyne, pag nag-extrafascial hysterectomy sila. So, at this point, gusto ko kayong i-orient sa mga ligaments that are important to us. So, this is your uterus. These are your fallopian tubes. Ito yung ovaries nyo. So, ang una namin gagawin usually is to perform ligation of your, hindi kita dito, I'll just draw. Ayan. Your round ligament. So, your round ligament is below your fallopian tube, pababa to the labia majora. Okay, so yan. Yan yung una naming ilaligate, your round ligament. Okay? So again, dito siya sa anterior surface ng uterus mo, below the point where the fallopian tube attaches to your uterus. Okay? So yan yung minsan na laligate on bilateral tubal ligation. Kaya important before kayo mag BTL or bilateral tubal ligation, kailangan mag-visualize yung fimbria. Okay? Kasi yung iba, nagkakamali sila, yung round ligament, yung nakakagip nila, ito yung nalaligate nila. Okay, so when we perform total hysterectomy, ito yung una naming ilaligate, si round ligament. So next naming ilaligate is si IP na tinatawag, your infundibulopelvic ligament. So this suspends your adnexa, particularly your ovaries and the surrounding fallopian tube, to the posterior abdomen. Okay, so palikod yan, si infundibulopelvic or ligament. Ang important sa kanya is, andito galing yung main blood supply mo ng ovary. So si ovarian artery nasa loob niyan. So important na maganda yung ligation mo at this point kasi pwede kang mag-bleed out if hindi maganda yung pagkakatay mo sa infundibulopelvic ligament. So kung dito, sa view na to, sa sagittal view, andito sa infundibulopelvic ligament. Alright? Okay, so next na ligament na important to us is your broad ligament. So makikita mo siya itong fan sheet, no? Na ligament below your adnexa, below your fallopian tube and your ovary. Okay? So yan, yung fan sheet na yan, that's your broad ligament. And the thickest portion of your broad ligament will make up your cardinal ligament. Pag tinanong kayo ano ang major support ng vagina, ng cervix, ng uterus, it's actually the cardinal ligament. Okay? Ito siya, yung thickened portion below the uterus and surrounding your cervix, no? Si cardinal ligament. What's the other name of your cardinal ligament? Transverse cervical ligament. Kasi as you can see, nasa side siya ng iyong cervix. Meron din siyang proper name, which is your Mackenrod ligament. But most of the time, we just refer to this as your cardinal ligament. Okay? So your other important ligament, which connects your posterior uterus to the sacrum, particularly S2, S3 level, is your uterosacral ligament. So ito yung mga nilaligate namin. No? So important malaman tong mga ligaments, lalo na dun sa mas advanced na hysterectomy, which is your radical hysterectomy. Okay? So yan yung mga important ligaments that you have to note. Pero ang importante in terms of extrafascial hysterectomy, kaya siya extrafascial, is because we include the pubocervical fascia in your specimen. Kapag walang pubocervical fascia ang specimen mo, sobrang white nung cervix mo. Okay? Yung cervical part ng specimen mo kasi nakalbo mo siya. Pero pag meron kang pag nag-extrafascial hysterectomy ka, kasama siya. No? So, hindi siya ganun ka-white yung itsura niya sa gross specimen. Alright, so that's your extrafascial hysterectomy for you. Okay, so for example, your patient already underwent extrafascial hysterectomy. So, paano mo na isi-stage yung patient? So, na-open mo na yung uterus, nakita mo na rin yung, na-assess mo na rin yung lymph nodes intraoperatively. So, ganito mo siya sinistage. So, isa-isahin natin to guys. Okay, nagtatanong sila ng staging sa board. So, yun pa lang, aralin na natin siya. Ito ang pinakamadaling cancer staging, believe me, compared to ovarian versus cervical cancer. So, how do you memorize this? I will help you with the mnemonics that I know about this staging. So, pag sinabi mong stage 1A, the myometrial invasion of the endometrial tumor is less than 50%, so less than half. 1B, if the invasion into the myometrium is more than 50%. Stage 2, if the cervical stroma is involved. Remember guys, before kasi, ang stage 2 includes cervical glands, no? So, hindi lang dapat glands yung involved sa stage 2. Dapat talagang nandun siya sa meat ng uterus, nasa stroma ng uterus yung tumor mo. So, that's stage 2 for your endometrial carcinoma. Stage 3 is beyond the uterus already. So, itong stage 1 and 2, nasa uterus pa yan. Yung stage 2 na may cervical stromal involvement lang compared to stage 1. Pero sa stage 3, beyond the uterus na siya. 3A, if it involves the adnexa or the serosa of your uterus. Stage B, if it involves the parametria or your vagina. Okay? B. Kaya siya stage 3B because vagina. Vagina yung involved or yung parametrium. Your parametrium, remember, if we review your anatomy, it's this one, no? It is lateral to your cervix. Pag stage 3C naman, C stands for kulane. So may lymph node involvement yan nga. C1, if your pelvic lymph nodes are involved. C2, kapag mas mataas na yung involvement niya, nasa para-aortic lymph nodes na. Now, stage 4, just like your other cancers, no, this is already beyond your GYN organ. So beyond already the system that that is primarily involved. So stage 4A, if it's the ones that are just beside your pelvic organs, beside your uterus, which are your bladder and or bowel mucosa. Note na dapat bowel mucosa, okay? Ibig sabihin, nasa loob nung bowels yung tumors na. Stage 4B, if you have Stage 4B, if you have signs of distant metastasis, including intra-abdominal organs and inguinal lymph nodes. So, nasa labas na yung lymphadenopathy mo. Kapa mo na siya sa inguinal lymph nodes mo. Okay? So, that's your endometrial cancer staging. So, for example, si patient mo, nung binuksan mo yung uterus, you see na meron lang siyang less than 50% myometrial invasion. So, ano na action? Ulit. So, for example, si patient mo, less than half lang ng myometrium yung involved. Or sige, gawin natin, yung hanggang endometrium lang siya, wala siyang myometrial invasion. So, ano na yung stage ni patient mo? Dito na, at this point, makaka-commit ka na, no? May intraoperative stage ka na. So, endometrial adenocarcinoma, endometrioid type, FIGO grade 1, intraoperative stage 1A. Pwede pa po ba yung mag-upgrade, doktora? Pwede pa siyang ma-upstage? Yes, depende sa histopath findings ng patient mo, no? What if kasi grossly, wala ka naman nakikitang lymph node involvement. Pero yung pala, involved na si para-aortic lymph nodes mo. So ano na yung stage ni patient? She is at least stage 3C, C for colane, and 2. Kasi di ba, C1 is for your pelvic lymph node, C2 for your para-aortic. Okay, so example lang yon. So, syempre, since ito ay final diagnosis, kailangan isama mo yung procedure na ginawa mo kay patient. Okay? Naget? Alright, so let's move on to another case of postmenopausal bleeding. So, we have a 51-year-old G7T77007, so grand multipara na to, who consulted for foul-smelling vaginal discharge and postmenopausal spotting. Speculum examination showed a fumigating necrotic mass. So, pangit tingnan yung mass na ito. Measuring 2 by 2 centimeters at the posterior lip of the cervix. So, what should you perform to confirm your diagnosis? So, ano muna yung iniisip mo? Meron siyang foul-smelling discharge, meron siyang postmenopausal spotting. This is likely a case of cervical carcinoma. So how will you confirm your diagnosis or your suspicion? You must perform cervical punch biopsy. Ipapap smear mo pa ba to? Hindi na. Remember, what is pap smear? It's a secondary form of prevention, meaning hindi pa evident yung disease pero tinatry mo siyang i-catch. Okay? So dapat, kapag meron ka ng evidence of disease, hindi mo na siya ipapap smear. Hindi ka na mag-screen for it. Dapat hanapin mo na yung definitive histopath diagnosis ng patient. So, for that, we perform cervical punch biopsy. Okay? So, cervical cancer, ano ang necessary cause niya? It's HPV infection or human papilloma virus. Okay? So, that's your HPV. So, cervical cancer is a sequelae of persistent HPV infection. Typically, in an immunocompetent patient na hindi naman repetitively exposed to your HPV or this virus that is typically transmitted via sexual intercourse or sexual contact, dapat makiklear mo yung HPV infection. Okay? So that's for your immunocompetent, lalo na sa mga young patients. Nakiklear naman nila yung HPV infection. So, ang HPV is marami siyang types, no? Marami siyang variants. Ang notorious na nakaka-cause ng cervical cancer are these two, 16 and 18. So sa books, at least 80% of your squamous carcinoma of the cervix are caused by your HPV 16 and 18. This is the reason why yung earlier na HPV vaccines, your quadrivalent vaccines, they address 16 and 18. And may added protection sila na against warts, which are caused by your HPV 6 and 11. Okay? So yung Cervarix, which is bivalent lang, 16 and 18 lang yung ina-address niya. Merong mga newer vaccines na anti-HPV, non-valent na yun. So mas marami na silang high-risk types na ina-address. So, dahil HPV ang necessary cause ng cervical cancer, anything that incessantly exposes you to HPV infection will cause cervical cancer. So ano yung mga examples na yun? So these are just some of the risk factors. Hindi ko nababanggitin isa-isa lahat. Kasi ang important dito, alam nyo yung theme. Ano yung underlying risk factor behind all these risk factors? So one is high parity. Sa older guidelines, sa older CTGs ng POGS, or ng SGOP, ng Society for Gynae-Onco, dinefine niya yung high parity of at least 7. So si patient natin, di ba, G7, P7 siya. So ito yung risk factor ni patient. Having multiple sexual partners, so wait, let's go back to that thought. Bakit ang high parity, bakit siya risk factor for cervical cancer? So kapag buntis ka kasi, no, nag-iiba yung immunologic response mo, you become more susceptible to the HPV, to the virus that is HPV. And also, on top of that, nag-i-evert kasi yung cervix mo during pregnancy. So when that happens, your cervix becomes a good environment for persistent HPV infection. No? So pwede yung mag-persist, and eventually the long-term sequelae of that is cervical cancer. So another risk factor is having multiple sexual partners or having been exposed to the HPV, to HPV. Yun na, HPV. Virus na pala, HPV. At an early age. At age 14 or earlier, or 2 years from menarche. So that's considered early coitus. Okay? So again, itong high parity early coitus and yung specific number ng sexual partners defined yan sa earlier editions ng CTG ng FGOP. Okay? So, but essentially, basta alam mo lang na persistent HPV infection, therefore, kapag mas exposed ka sa HPV, mas mataas yung risk mo for having cervical cancer. Okay. So, as I mentioned a while ago, ito yung important, dito important yung alam mo yung anatomic structure sa management ng cervical cancer. Ano na ang mainstay mo na treatment for across all stages? So the mainstay of treatment is chemoradiation actually. So yung chemoradiation, kaya ka nagki-chemo concomitant with your radiation is gusto mo maging radio-sensitive yung cancer cells mo when you perform radiotherapy. So yun yung mainstay treatment talaga. Across all stages yan. However, in earlier stages of cervical cancer, you may perform surgery in the form of radical hysterectomy. Diba? Kung kanina si endometrial cancer is extrafacial, pagdating mo kay cervical cancer, yung type of hysterectomy mo is now radical hysterectomy. So pag sinabi mong radical hysterectomy, kaya siya radical kasi talagang sasagarin mo yung ligaments mo. Up to the dulo talaga yan. So yung cardinal ligaments mo, up to the attachment niya, as close to the pelvic wall as possible, dun mo siya i-dissect. Okay? Okay. Basta ganon. Talagang sasagarin mo siya up to the attachment ng ligament towards the pelvis. So si uterosacral, ganun din. Up to the, as much as possible, no, as close to the sacrum as possible, ang tanggal mo ng radical hysterectomy specimen. Tapos, ang isa pa kay radical hysterectomy, part of the vagina you also remove, no? Sa extrafacial, saka yung typical mo na hysterectomy, hindi naman kami nag-i-include ng portion ng vagina. But in radical hysterectomy, we include parts of the vagina. Bakit ganun, Doktora? Bakit kailangan mo mag-include ng parts ng vagina at bakit kailangan mong sagarin yung mga ligaments up to their attachment? This is because loco-regional ang spread ng iyong cervical cancer, no? So it spreads via local invasion. So it also spreads via the lymphatics, pero ang primary mode niya ng metastasis to the other organs is through local invasion. So local regional yung kanyang spread. So kaya mas sagad ang pag-dissect mo with radical hysterectomy. Naget? Okay, so we'll now move on. Okay, so ito guys, I'll leave the staging up to you, no? Hindi ko na iisa-isahin. May gusto lang akong i-emphasize na certain things about your cervical cancer staging. So note no na, hinighlight ko yung less than or equal to sa 1A1, pati 1B1, less than or equal to yan, pati din sa 2A1. Bakit? Kasi ang nasa printed na CPG na release nung, I think, 2018, greater than itong 3 millimeters na to, greater than din itong 2 centimeters na to. So, kinorek na yan recently. So, after na-print yung CPG, kinorek na siya ng FIGO, no? Yung staging niya. So, just take note, alalahanin nyo lang, yung equal to is dapat nandun siya sa lower stage instead of dun sa higher stage. Okay? Kasi yung dun sa mga previous editions ng guidelines, at saka yung mga nakaprint na guidelines kasi, greater than or equal to, nakalagay siya sa 2A. So, dapat less than or equal to. Naget yun? So, si equal sign, nandun siya dapat sa lower stage. Yun yung ifa-follow, okay? Even si Figo, nag-print out din siya, nag-publish din siya online na greater than or equal to, nandito, sa higher stage. So, dapat dun siya sa lower stage. I hope that's clear, okay? So, I leave the staging up to you guys. Pati itong kung paano itong ano yung 1, difference ni 1, sa 2, sa 3, and sa 4. I'll leave that up to you in the interest of time. So bakit important na na-note nila yung correction na yun, no? Kasi di ba mag-iiba yung management mo? Because sino ba yung mga pwede mong i-radical hysterectomy? Okay? So ito yung mga stages na pwede mong i-radical hysterectomy. Si 1A, obviously, because microscopic lang yung diagnosis mo dito ng cervical cancer. So definitely, pwede mo siyang i-radical hysterectomy. Si 1B1 saka si 1B2, pwede mo rin silang i-radical hysterectomy kasi ang greatest diameter or dimension ng iyong tumor is less than or equal to 4 centimeters. Okay? So yun yung marker nyo ng pwede kayong magkaroon ng action. Okay? So pag less than or equal to 4 centimeters, pwede kayong mag-radical hysterectomy. So ano pa yung isa mong stage na pwede ka mag-radical hysterectomy? Si stage 2, 1A. Kasi less than or equal to 4 centimeters yung greatest diameter niya. So beyond the stage, hindi ka na pwedeng mag-radical hysterectomy. Okay? So imagine nyo na lang, essentially, lahat ng stage up to stage 2A1, pero isi-skip mo si 1B3. Okay? Kasi meron siyang tumor size na greater than 4 centimeters. So imagine kung hindi nila na-correct yun ng maayos, no? So makakasama ka pa ng stage 1B3 saka stage 2A2 na i-radical hysterectomy kung dito yung greater than or equal to na sign. Okay? So ang marker mo na pwede ka mag-radical hysterectomy if the greatest tumor size is less than or equal to 4 centimeters at up to stage 2A1. Alright? Yan. Okay. So one more thing that I want to emphasize regarding the new staging of cervical cancer is we have a new stage, stage 3C. Dati itong stage 3 hanggang stage 3B lang siya, but with the newer staging, may stage 3C na. So bukod doon, meron pa siyang tinatawag na R and P notation. So ano ibig sabihin ng R and P notation? Before kasi, ang classic answer sa tanong na alin ang gynecologic cancer na via clinical staging mo lang sinistage, the answer is cervical cancer. Okay? Purely clinical ang staging ng cervical cancer. Pero ngayon, meron na tayong tinatawag na radiologic and pathologic evidence of metastasis. So, kapag isusulat mo to, meron kang stage 3, C1, tapos maglalagay ka ng subscript, either R or P. Depende kung paano mo na document yung metastasis to the pelvic lymph nodes or the para-aortic lymph nodes. Kapag via imaging or via MRI or CT scan, you see that it's 3C1 with a subscript of R. Okay, lowercase na R. Kapag via pathology, meaning na biopsy mo tong lymph nodes na to, then you put P instead of R. Okay? Na-get? So, yun yung bago sa cervical cancer staging. Alright? Ayan. So, ito lang guys. Paano nyo ma-distinguish on rectovaginal examination yung parametrial involvement or pelvic wall involvement? Remember guys, di ba si stage 2B, meron siyang parametrial involvement pero wala pa daw siyang pelvic wall extension. Ang description nun sa rectovaginal examination ay nodular pa lang siya. Okay? So, 2B ka pa lang pag ganon. Okay? So, ibig sabihin ng nodular, ito makapalpate mo na itong mapapalpate mo na parang medyo makapal na yung parametria mo, no? So, parang, nodular siya kasi nandito pa lang yung cervical cancer cells mo, yung cervical cancer tissues mo. However, if it extends to the pelvic wall, like in this picture, no, abot na siya sa pelvic wall, ang description mo na sa parametria mo ay fixed. So the moment na i-describe yan ng resident mo or ng fellow mo na bilateral parametria are fixed, automatic na yan, you know that there is extension to the pelvic wall. So stage 3B na siya. Na-get? Okay. So yan, let's now go to the other chief complaints sa postmenopausal patients. So ito yung isa nilang chief complaint aside from postmenopausal bleeding. So they could present to you with prolapsing introital mass. So ano kaya ito, no? Yan. So you have a 60-year-old G8, P88008. Ang chief complaint niya, buwa. Buwa is the Tagalog term for your pelvic organ prolapse. Doktora, meron po akong buwa. So yan, madalas namin yung naririnig sa outpatient department. So for the history of this patient, ang sinasabi niya sa iyo is she has a prolapsing introital mass which she observes when she's coughing or while carrying her grandchildren. So may increased intra-abdominal pressure. So doon niya mas nanonote na lumalabas yung kanyang buwa. Other than this, she has no associated symptoms except for difficult voiding. Doktora, mahirap pong umihi. Para po makaihi ako, kailangan ipasok ko muna yung buwa para malabas ko yung ihi ko. So we actually have a special term for this na yung mga urogyn, they call this splinting. So you perform digitation or you reduce the prolapsing mass to be able to void or to defecate without difficulty. Okay, so bakit nagkakaroon ng ganong symptoms? Because kasama sa nagpo-prolapse mo is part of your bladder wall. So this is what you call cystocele. So pwede ko rin may rectocele, yun naman yung counterpart niya. Pag part of your rectum ay nagpo-prolapse with your pelvic organ prolapse. Okay, so hindi lang uterus ang lumalabas kapag meron kang buwa or pelvic organ prolapse. It's also your surrounding organs. Alright. So ano ba ang number one risk factor mo for developing pelvic organ prolapse? It's vaginal childbirth, okay? So this increases the risk up to 10 times, no? Single childbirth pa lang yon, vaginal childbirth. So this patient, naka-8 daw siya. So grand multiparia ito si mother. So more 80 times ang kanyang risk for developing pelvic organ prolapse. So these are the other risk factors and associations with pelvic organ prolapse. So, bakit matagal naman nang nabuntis to si mother, matagal naman yung childbirth niya. In between naman, hindi naman lumalabas or nagmamanifest yung pelvic organ prolapse. Bakit ngayon na lang na 60 years old siya? This is because the patient is already postmenopausal. So, mababa na yung estrogen ni mother. So, because of that, weaken na rin yung connective tissues in your suspensory ligament. So because of that, nagmamanifest na yung pelvic organ prolapse in this age group. So how do you treat pelvic organ prolapse? You can do expectant management, no? Pag hindi naman worrisome for the patient, yung pelvic organ prolapse, pwede lang siyang i-observe. You can also use pessary. So pessary, it looks like a donut. Most of your pessaries look like that. And then you insert that into your introitus para mapigilan yung pag-prolapse nung uterine, nung pelvic organ mo, particularly your uterus. You may also perform surgery or vaginal action. You may also perform surgery in the form of vaginal hysterectomy. So yung position niya kapag i-OR mo siya is naka-dorsalisotomy position ka, and that's how you remove your pelvic organ prolapse, your uterine prolapse. Okay? Okay. So how do we assess patients with pelvic organ prolapse? We have what we call the POP-Q scoring system, which stands for POP quantification. Okay? So we have 6 points measured at the vagina with respect to the hymen. Okay, so ito yung anatomic landmark nyo, si hymen. Okay, so ito si hymen sa sagittal view. Dito sa view na to, from the dorsalisotomy position view, ito si hymen. Okay, so siya yung magmamark ng zero mo. So, di ba, remember dun sa labor, kung si zero is marked by your ischial spine, in POP-Q, ang zero mo ay si hymen. So any point above the hymen, ibig sabihin nasa loob siya ng vagina, dapat negative yung score niya. Anything below the hymen, meaning nasa labas na siya ng hymen, nasa labas na ng introitus, dapat positive number yung kanyang score. Malinaw? So there are 6 points na measured at the vagina are your anterior wall, BA, C, AP, BP, and D. So, isa-isahin ko yan para sa inyo para maintindihan nyo. No? So, gusto ko lang na maintindihan nyo siya at this point. So, mamaya nyo na i-memorize later on pag nag-rotate na kayo sa OB. So, aside from these 6 points na to, na later on ko na i-discuss in full detail, you should note that there are 3 additional values that we write in the POP-Q score. So, meron tayong 3x3 matrix. So, si genital hiatus or si GH, ano ibig sabihin ng GH? GH is yung measurement mo between the external urethral orifice to this one, no? To the posterior na midline hymenal area, okay? So, yan si GH. Basta ito siya. Yan si GH, okay? So, when you say perineal body, ang perineal body is itong dulo ni GH up to the anal opening. So that is your perineal body. So this should be PB instead of PH. Okay? Perineal body to. When you say total vaginal length, it means na i-reduce mo, ipapasok mo yung nagpo-prolapse na mass, and then you get the total vaginal length. So ganyan mo i-measure si total vaginal length. Ano ang special kay total vaginal length? So lahat ng to, yung itong first row and itong third row, pati itong genital hiatus sa perineal body, dapat yan nagbabalsalva, full valsalva yung patient. Papairihin mo siya habang i-measure mo. Except for total vaginal length, wherein kailangan naka-relax si patient at ipapasok mo or i-reduce mo yung prolapsing mass. Na-get? Now we'll move on to the more difficult parts of your POP-Q scoring, which are the 6 points. Itong first row sa itong third row. Okay? So, ano bang ibig sabihin ni AA? Si AA, it's 3 centimeters from the hymen sa anterior wall mo. So, ibig sabihin nito, ang values niya ay pwede lang from -3 to +3. Hindi ka pwedeng mag-4. Okay? Hindi pwedeng +4, okay? Take yung POP-Q score mo pag yun yung nilagay mo sa anterior wall. So, siya ay, kumbaga, arbitrary point na measure from the hymen to that of the anterior wall. So, ito si AA. Kung ito yung vagina mo, ito si AA kapag nasa normal position siya. So, nasa -3 siya dapat. Okay? So, ang counterpart niya sa posterior wall mo is si AP. Okay, so sa posterior wall mo, from the posterior hymen, 3 centimeters from it, yun si AP. So gaya ni AA, dapat si AP ay -3 to +3 lang yung value. Okay, na-get? So -3 to +3 lang. Alright? So ano naman si BA? Si BA, siya yung most prolapsed portion ng anterior wall. Okay, so kung sa normal position mo ng pelvic organs, si BA dapat nandito siya sa loob. Dapat negative yung value niya. Okay? So kapag lumabas yan, yung most prolapse anterior portion, yun si BA. Si posterior wall BP naman, siya yung most prolapse portion ng posterior wall. Okay? Tapos si C, siya si cervix. Okay? Ito si cervix. Si posterior fornix, iba pa siya. Ito si posterior fornix. Na-get? So ito si cervix, ito si posterior fornix. Sa drawing na to, ito si posterior fornix, ito si cervix. Okay? So lahat to negative values, yung anterior wall, yung AA, yung BA, yung cervix, yung AP, yung BP, yung D, lahat yan negative values dito sa picture na to. So paano nyo siya madaling maintindihan? Essentially, kapag halimbawa gagawin mong ililipat mo itong drawing na to, no? So si A, si B, si C, si D, si P, si A, para siyang yung matrix ng POPQ. Ito si A, ito si B, ito si C, D, B, P. Na-get nyo? No? So para siyang, kumbaga kung i-drawing mo siya, ito yung cavity mo, vaginal cavity mo. Ganyan mo siya i-imagine. Such that, halimbawa, pag meron kang prolapse, pen ulit tayo. Diba andito si A? Tapos andito yung A mo originally, nasa -3. Pag halimbawa, nag-prolapse siya of the hymen na si A mo. So, yan ay 0, ha? Tapos halimbawa, yung most prolapse anterior mo. So, from here, ito dapat yung anterior wall mo, lumabas siya dito. Tapos, si C mo, lumabas din siya dito. And then, si posterior fornix mo is somewhere here. Si posterior wall mo, na most prolapse is somewhere here. Ayan. Tapos, si posterior wall na 3 centimeters from the hymen is somewhere here. Ayan. So, ganun mo siya i-measure. Nag-gets nyo ba? So, essentially, parang kung drawingan mo tong POPQ score mo, para talaga siyang essentially drawing ng loob, yung sagittal view ng iyong pelvic organ. So, ganun mo siya maaalala. Okay? So, ganun din siya na ituro sa amin. So, para siyang cross-section of a patient in terms as a sagittal view. Okay? So, kung hahatiin mo pag dito yung patient, ganito mo makikita si POPQ para mas lalo nyong matandaan kung anong components ng 3x3 matrix ni POPQ. Okay? Na-get? Okay, so in terms of staging, para madali nyo siyang maalala, ang tatandaan nyo lang si stage 2. Bakit si stage 2? Si stage 2 ay si -1 to +1. So, madali mo siyang maalala kasi i-adjust mo na lang siya. Depende doon. So, less than, pag mas mataas siya than -1, yung leading point, edi nasa stage 1 siya. So, isa nyo pang tatandaan is si TVL -2 or total vaginal length -2. So, sa stage 4, which is the last stage in your POPQ staging, kapag ang leading point mo is more than your transvaginal length -2 centimeters, or otherwise, meron ka ng tinatawag na complete eversion, it means nasa stage 4 ka na. Okay, bigyan kayo ng example para mas ma-realize nyo siya. O, for example, ganito. So, ang titingnan mo dito, titingnan mo kung meron kang point beyond +1. Kasi yun si stage 2. So, yes, meron, di ba? So, titingnan mo na next kung stage 3 or 4 siya. So, ang next mong titingnan is si TVL, which is this one. So, 8 -2 is 6. So, yung mga leading points ay less than 6 pa. So, ito ay POPQ, yung POP niya ay stage 3 pa lang. Na-get? So, another example. Okay, so ito naman. So, tingnan nyo, yung first row and second row, ang makikita nyo, ang leading points niya is nasa hanggang +1 lang. So, from -1 to +1, pag andun yung leading point mo, it means nasa 2 lang. Okay? So, for example lang, nasa ano ka na, for example, itong most prolapse na anterior portion ay nasa +7. So, since more than siya ng TVL -2, which is 6, then stage 4 ka na. Okay? So, paano naman guys kapag halimbawa na may history yung patient na total hysterectomy siya? Ayan, buburahin ko na yung uterus. Ayan, tanggalin na natin yung uterus. So, paano kung na total hysterectomy ka na? Paano mo na isusulat yung POPQ mo? Alin yung mawawala sa scoring system mo? So, kapag na-hysterectomy ka na, pwede ka pa rin bang mag-pelvic organ prolapse? Of course, remember, ang pelvic organ prolapse, it's pelvic organ, hindi lang yung uterus mo. So, pwede ka pa rin mag-cystocele and mag-rectocele. So, kapag ganun lang, ang mawawala sa POPQ score mo is this one. No? Mawawala na si posterior fornix mo. So, ang magkakaroon ka na lang is itong letter C. No? So, instead of the cervix, ang iyong i-note dito is yung length or yung level of prolapse ng iyong vaginal cuff. Vaginal cuff, ito yung, di ba, kapag na hysterectomy ka na, ganito na lang siya, di ba? Ito na lang yung matitira sa vagina mo. So, ito yung vaginal cuff. So, kung gaano ka prolapse yan, yun yung ilalagay mo dito sa C. Okay? Tapos wala na tong letter D, wala na siyang posterior fornix. Okay? Na-obliterate mo na kasi yan from the previous hysterectomy. Okay, so again guys, ito na yung mga natakal natin. Congratulations for finishing Genesis Gynecology. Ito yung mga topics or chief complaints na natakal natin through our gynecology lecture. So that ends my lecture for now. So congratulations for finishing this very long lecture on obstetrics and gynecology. I hope marami kayong mabaon na knowledge through this lecture, no? Gaya nga ng nasabi ko sa inyo during the first man kayo mag-OB gynae in the future, I hope ma-appreciate nyo yung concept man lang or yung principles of management behind our specialty. Kasi kahit hindi kayo mag-OB in the future or kahit hate nyo pa yung OB, for sure, meron kayong mother, meron kayong sister, girlfriend, friend na girl, or nililigawan na nangangailangan ng OB/GYN expertise nyo in the future. So that's it for now. See you in the next lecture.